Thank you, Sharon. Thank you, John. Thank you, everyone. It's a great privilege for me to be speaking at IOTOD, a great conference, and it's an even greater privilege to be one of the final speakers, maybe the final speaker, I understand. So this puts a lot of stress on me, and so I know I've said this before, but it's true. There are different ways one can manage stress. One is drinking alcohol, and I was looking for alcohol at the in-between session, but there was only tea and coffee. And I understand coffee is good for your liver, but alcohol is better for your stressed brain. Another way of managing stress is moving. So I'll take the opportunity having a microphone so that I can get the stress down and keep focused. My disclosures and the learning objectives. Well, this is quite a challenge because the objective of this talk is to actually go over things that have been discussed throughout these 2.5-day meeting and clarify the characteristics of addiction or dependence and describe patient's perspective and have an overview of our treatment goals. So, by the way, what is addiction? One way of looking at it is to check the individual diagnostic criteria. Now, if you're from the US, you're an American, you will look at the DSM-5 criteria. If you're someone from Britain, I understand from previous speakers, you will be looking at ICD-10. Being European, and without any time limit, being French, I look at both. And if I look from the back row of the room, it's fairly similar. It's fairly similar. If I look from the front row, of course, there are differences. But even there, what you can see in both diagnostic criteria, number one, there is a timing. So this is a condition that is not a temporary condition because it takes time to determine that it exists. We need to have at least 1 year looking back to determine that there is addiction or not. And then if you look at the criteria, it's a kind of potpourri, if I may use this word. So you have a mixture of things that are consequences of addiction and others that are maybe core to addiction, things that are the drive of addiction. And this is important for us to keep in mind, the core and things around the core, a constellation, if I may say so. The core is what we now accept as loss of control, relapse, and craving. There's a language issue here. Craving is a French word. And I apologize for putting up a French word because I don't know the English translation. I'll come back to that. Relapse, everyone understands, and relapse is the big challenge for our patients, for their families, and should not be a challenge for health professionals. For a long time, in the addiction field, and in general as health providers, as doctors, as psychologists, we are attracted to understanding the causes of a condition, and we want to act on the causes of conditions. However, in the addiction field, we have very little information about causes, but we have lots of statistical information about risk factors and pre-existing factors to addiction. And we sometimes make a confusion between a risk factor, a pre-existing factor, and a causal factor. And this is a challenge for practicing addiction specialists, because of course, most of the people that we will meet in our addiction clinics have the risk factors or the pre-existing factors. So we tend to consider them as causal factors. But what general population epidemiological data show is that the majority of individuals that have these risk or pre-existing factors never develop addiction. For example, child abuse. The majority of people that are exposed to child abuse do not develop addiction. But many of those that do develop addiction report child abuse. So that has been a big challenge. And over the years, we have been more careful to the consequences of addiction. And this initially was probably related to the HIV epidemic, and somehow the HCV epidemic is taking over. So addiction has consequences, and we should keep these consequences in mind. What is difficult in clinical practice is that when we meet an individual, he's an individual, and he has a mixture of pre-existing factors, current factors, and consequences of this special condition that is addiction. Please keep in mind that all this schema can be understood from an environmental, individual, and developmental perspective. These things are not stable, they're not static, they're dynamic, and they can be studied from a scientific perspective by sociology, psychology, and biology. And healthcare, medicine, cuts across these three major scientific specialties. Now, let's not forget the whole picture. We have discussed a lot during this meeting about comprehensive care and tying up things together. But to tie up things appropriately, it's good to know what you're tying up. So it's important to also tease things apart. And we need to keep in mind that when using something that is potentially addictive, you are exposing yourself, the individual is exposed to acute toxicity, but also to chronic toxicity, and also to the risk of addiction. And these things should not be lumped together. There are three different things that will need to be addressed. Of course, those with addiction are more users than those without addiction, but they are also exposed to acute toxicity and chronic toxicity, so we should be aware of that. And the general population of users that are not addicted are also exposed to acute toxicity and a bit of some of the chronic toxicity. So this slide is just to look at the dynamics of things, that all user, and we all know that, even if sometimes we forget it, all users, including of substances like opioids or heroin, are not addicted. And we all know, but it's important to keep it in mind, only a minority of people that use a drug in general, or opiates specifically, will actually develop addiction. This is just to remind that there is an important number of individuals that will not pursue after a first use, and initially those that pursue individually do not experience problems, eventually will stop after a few months or a few years of use, or not stop and continue using, and finally one day die, which you are aware of happens to everyone at the end. Just to give time for the translators to be sure everyone is aware of that. How does this work? Well, when there is no addiction in quote-unquote normal use, use will adapt to individual and contextual consequences. So the user will take into account the consequences of his use. This is very different for those that develop addiction. In addiction, the ability to take into account the consequences of use is impaired. So individuals will continue using, the use will become, in its expression, more compulsive, systematic, automatic. And this will, as you know, problems build up. Something we kind of forget sometimes as treatment providers because we are not careful enough to listen to our patients. Then individuals request help to stop or suspend their use. But of course, as you know, they relapse. And relapse is involuntary relapse. So the big challenge for many years was to understand what is happening here. And there is a wealth of evidence now that has accumulated over the past 30, 40 years, and more precisely over the past 5, 10 years, to say that craving is likely the drive of relapse and involuntary use in addiction. So this is data from Melina Fatsias, a clinical researcher working at the University of Bordeaux, that has been able to show both in laboratory human lab conditions and in community study, ecological momentary assessment studies, that craving predicts relapse both in the following months, but craving also predicts use within a few hours. So we can actually, and this might look shocking to many of you, and I apologize for that, but maybe things are much more simpler than we thought. And relapse is the big challenge in addiction. And there is wealth of evidence now, as I said, that craving is maybe not the only mediator of relapse, but at least the best documented and the most likely major mediator of relapse. And so, just to explain craving, what does it mean? Craving is not just a strong desire to use. It's a desire, a wanting to use that is not necessarily strong, but that is inappropriate. That when the user experiences this phenomenon, he experiences wanting to use at a moment where he would like not to use. Many of our patients that experience this don't have the words to communicate it. It's our job to give them the words to enable them to communicate with us. Otherwise, they act out. So the craving, and there's other data, and this has been talked in the first half day about how cues and generic cues, but also individual cues trigger craving, which determines relapse. So if you push it a bit further, well, we have a model for a disease, and there could be a debate, what is a disease? But if such a thing exists, we could have a disease with an objective sign, relapse. That is something you can document without asking the patient, and a predictor symptom, so something you need to communicate with the patient to access it, craving. Now, what do patients report? What do patients report about their use? Well, this is also well known. There are many motivations an individual, whether a patient or not, may report for use, and it's something that we all experience when using. It's a reward motivation, so a pure hedonistic experience, or a relief motivation, something that you have a pre-existing condition and you are looking for relief. And these two things are very different, even if they drive similar behaviors. Individuals that report, and some individuals report only reward motivation, only relief motivation, and some individuals report both. And this can change with time. Individuals that report reward motivation have a preferred choice for more reinforcing drugs, or opiates, for opiates. People who are looking for a relief motivation are more interested in less reinforcing drugs and a wider type of medications, of drugs, sometimes medications, eventually opioid analgesics. Individuals that report reward motivation more often report personality traits, sensation-seeking, but no specific psychiatric comorbidity. On the other hand, individuals that report relief motivation more often report psychiatric comorbidities. And you have many crossover. So the field of addiction treatments is changing and complex. It's changing with our better understanding of what is addiction, our better ability to tease apart what is core, what is pre-existing conditions, and what is consequences. And we should always have in mind all these elements together. We need to pull everything together. Throughout these 2.5 days, and this has been reviewed with the just the previous session that has gone over all the things we have discussed through these 2.5 days. And I'll just remind you briefly about this issue of older patients. Because we have developed more effective treatments, our patients are not dying anymore, so we are confronted with this new population. The issue about opioid analgesics. Why is it that we are finding people developing addiction with opioid analgesics? And there's lots of discussion, but maybe we should be more careful to pre-existing psychiatric conditions not well diagnosed and access to treatment. Psychiatric comorbidities, of course. There are also other issues that we can act on. The overdose workshop was extremely important because it gives us what is the most efficient, I was reminded yesterday, to strictly prevent overdose is access to treatment of opioid addiction, methadone, buprenorphine, and MAT, medication-assisted treatment. If that is not available, or if it's available, then you should, and I'm almost done, you should add naltrexone. But naltrexone does not prevent overdose. It's early access to treatment because you use naltrexone once someone is overdosing already. And then we've seen on the issue about HCV. The HIV epidemic is over. It's not a concern anymore, but the HCV is in front of us. And hopefully, if we're all very careful, will be behind us in a few years' time. So to conclude, how to achieve ideal treatment, how to achieve all the manifesto we voted for, well, maybe we need to keep in mind the whole picture. We need to integrate, but to do good integration, it's important to tease apart things. Thank you.
Thank you, Marc. That was really a very nice overview, and we certainly appreciate you trying to synthesize and, well, successfully synthesizing everything that has been discussed previously. We have a few minutes for questions. If anyone in the audience has a question for Professor Auriacombe, please just raise your hand. It's very hard to see. Yes, sir.
J'ai une question méchante, monsieur. Vous avez posé que le mot craving, c'est un mot français. Je pensais que c'était un mot anglais. Pourriez-vous expliquer ça, je vous en prie?
All right. You got to translate.
Yeah, my French-speaking colleague is saying that I mentioned craving was a French word, and he thought it was an English word. And so he's asking me to clarify that. So well, the French word craving is a medical technical word in medicine in the addiction field. And as you all know, in every languages, technical words, some of them are very specific to the special area. And usually they are difficult to pronounce, and everyone knows that they don't understand what it means. But we have some technical words that exist in the general public. For example, I think of one in psychiatry is a manic episode. The understanding that we have as medical professionals, as psychiatrists, of what is a manic episode is very different from what the general population understand by being manic. So there's misunderstanding. So in French, we use the word craving to describe this special experience I try to describe in English, which is craving in addiction is not just wanting a lot. It's not just a strong desire. It's a desire that is not appropriate to where you are and to actually what you would like. And the patients describe it very well. What makes me uncomfortable is not just that I'm wanting, it's just that I'm wanting but not at the right moment. That's a subtlety. And that also is, and I'm not making a short answer there, I apologize, but this has contributed to, I made a short story and I presented things positively regarding craving, but I'm sure there would be people in the room that would challenge that. And some of the difficulty in the literature is how do you define craving?
Right.
And that's, so for the English-speaking community, it's a challenge because then you make a mix, there's a confusion between craving a special condition in addiction and craving that anyone can.
Chocolate.
Right.
When we want it.
Right.
And it's not inappropriate.
Right.
Yes.
So that's why, for example, to make it short.
So let me just do one follow-up question here. This is from our audience member, Dr. John Barnes. He says, do you see any relationship between craving and obsessive thoughts?
Well, they can be, yes. So, for example, our patients, we report that they dream, or usually they'll say they have nightmares about using, about things like that, or they think of using, but the experience, which is very different from when we're not addicted, and we anticipate that if I'm not speaking too long, shortly, I will be able to satisfy my desire for food and maybe a little wine in a few minutes.
20.
20, oh,
Yes.
Oh, that long.
Yeah.
I didn't realize.
But we have a lot of things we need to do before then.
So that's different
Yes.
than experiencing craving that becomes like an obsession and occupies a lot of the cognitive data that show that our patients have cognitive impairment. It's always important to control in the studies, and that is not always done. What is the level of craving?
Right.
Because craving builds up, so the patient cannot focus on his environment.
Okay. All right. Well, if there are other questions for Professor Auriacombe, I'm going to ask you to bring them up after we close the conference because we've got some business details that we need to get to.